All right, we reached 10 after. In order to reach quorum, we need 6. We have 5. I don't believe anyone else will be attending. I know a couple of the names on here are currently working.
I would like to propose that we write a letter to our New York State representatives to get to make amendments to the meeting rules and forms.
I think that's fair, and then you can go out. As far as executive session, we can, as an executive committee, decide that we want to send that letter. We can seek the endorsement of everyone via email, and that way we can have the backing of all of the members. I'm sure we're not the only region that's struggling with it as well. Some of the regions are geographically a bit smaller, so it's still a little easier, but especially Steuben County, it's a very wide and vast one. So people coming from all over the county have a hard time getting here sometimes. I have no problem that we have anyone who's eloquent and so good with words that I do not have. If you are willing to write something,
I'm happy to write something up on behalf of you.
all right. So we can have Dr. Kellogg write something out, and then it can go out to all the voting members and see if we can join in support of returning to at least a hybrid kind of function. That way we can get some of our members here and reach a quorum. So this is going to be 2 straight meetings where we're just below quorum numbers.
So,
Yep.
so now would probably be a good time to share this. There was a discussion at both STREMAC and Schuyler regarding the same issue, the difficulties for some regions to be able to reach quorums in today's town. You know, a lot of doctors travel, a lot of doctors are working multiple facilities and out of the North Country. The question is passed, and it's been posed to the Division of Legal Affairs on the basis that REMACs are standing subcommittees by statute of the regional council. That's why everything with the REMAC does winds up going to council for approval. And as such, the question was, the REMAC that is not a general policy making body, which would not be subject to the rules and regulations of the open meetings law. I.e., we could continually to go back to hybrid meetings, and the issue of forums would not be a problem. As it stands, the problems that everybody's really into are one to follow New York State open meeting, which obviously requires transparency and changes to how we do business, to the nature of the require unfortunately changes to the open meeting law, which is something that's well above the pay grade of the Department of Health. So I know that that's in process. I think that's the direction they're going to.
I don't think it'll hurt to have more REMACs coming in support and saying that it would greatly benefit our attendance and our ability to perform our duties.
Well, the other alternative is to, sometime last year, we changed the percentage of you have for a quorum, and we can change that again. To lower the percentage, so we get on with business.
Unfortunately, we changed that to be in line with statute.
My understanding is to be 50% plus 1. Currently with 11 voting members, 50% plus 1. I mean, we still have 6 reach a quorum. By my math right now, of our group, there are 6 full-time practicing emergency medicine physicians who work at one of 2 facilities, and they are in small groups at one of 2 facilities. Therefore, it is going to be very difficult to have all 6 ever show up at one time, because when one is off, the other one is working kind of situation.
That's another option. We could hire people.
Yeah.
We got a smaller group of Then more people, the ones that are not more likely to attend. As well.
And with that, I mean, having more support is never a bad thing, especially because everyone on the group is active in some form of EMS, whether it's ALS, BLS, or practicing out in the street on their own. But it makes it more difficult when, even if we have a new member, Danielle here wants to join us, if we reach 12, now it doesn't really help our quorum numbers, we actually have to go up by one. Because 50% plus one will bring us to 7 and 5 as our breakdown. I think everyone who's on the group still has a very active interest. And if Dr. Kellogg's letter helps produce some results, that'd be great for all of us to at least have a hybrid. I personally like, well, I live right down the block, so for me, it's a new point.
We lost sound. I did.
Oh, good. It wasn't just me.
No, it was me too.
He's talking about biospatial, it's one of their data collection analytical pieces. They'll be coming out. Can you tee up, Peter?
Can you hear me all right?
Yes.
Ready when you are, Peter.
All right. Well, we lost your audio there for about 5 minutes. So, all right. This is biospatial. Biospatial is a software as a service contracted by the Department of Health.
Have one other voting member on Zoom right now, like, what would be the difference?
Well, I mean, we could have called somebody on a cell phone and had them pop up.
Yeah, okay, I'll share.
I have the cell phone of 3 OP people on here that I could have just haven't been to and go on and continue doing what they're doing.
I would have been in Zoom.
Are you not able to hear us?
Didn't have this issue.
Apparently not.
I know that has called from her office and James has called from his office, so.
Did you have the various on Florida?
He's working.
Oh,
Yeah, well, I know James is working in the ER right now, Chris is working, I think Beth is working.
it's all those Florida pictures. Not the one.
I will send plenty of them at the end of March if you want.
Did you Ricky volunteers? What information, currently there's a new, director, thank you.
I heard that.
I've had her one, she was going to shift with, Congress. So I was hoping to catch up with her, we heard a little bit about It was big and really nice, because that's a 47 lasting for years. Fresh new days, I think she's now from, yeah, now I think.
You send a message to Peter to start.
Yeah, I'd love to have someone from.
Private market is interesting as well. I don't know if you guys know, he's a hospitalist. I mean, he is, he basically is our intensivist in recording, and he's pretty cowboyish. I mean, yeah, he's like low percent and everything, right? That is.
Are you able to hear us?
He's, but, he is well.
Is it a volume issue on our end or?
They were saying they couldn't hear us. It's
Pretty good, right?
So is Corning similar to like the UR hospital? Does the hospital oversee the ER?
recording.
Yeah.
No, the hospitalists, they do a lot of it, all of our ICU work.
Correct. Yeah. What are frustrating some point of where PAs are in ERs?
Let's,
They're not really under the new emergency position, they're in the hospital.
that's.
They're on Richard.
I heard the situation right now is the ER and the upper floor are under the same person.
And it's problematic for field providers.
Well,
because
The problematic thing for him is he also has an outpatient practice and he prefers the outpatient practice, so it makes it a bit difficult for getting him to come to a meeting like this. Great guy, but I think he works more jobs than I do, and I don't think that's a lot of it to say about anybody.
Yeah, I'm not really sure why he still does that. But anyway. I think
Mid-level that are on the floor at Corning, and then there are mid-level that are in the ED. They're completely separate.
Are you able to hear me now?
Well, in a few of the hospitals, like there's a disconnect between
I think their volume must be turned down,
the working the ER because.
I can hear you.
work For.
Certainly not their output volume.
Positions there. It's like
Yeah,
if they're
Peter, I can hear you
going to
too.
somebody on the telephone.
Well, would you guys like to know what biospatial is all about since it's on the screen in front of them and they're not paying
Yeah,
any
I
attention
mean-
to it?
We would be glad to listen.
Can you
to
hear us?
We can hear you.
You can hear us?
Yeah.
Try an ER doctor.
Okay, now try. You couldn't before because we were talking and you guys couldn't hear us.
No, we
We
could not.
talked and talked and talked and you guys kept rambling, so.
All right, well, let's talk for real now.
Ready?
So you ready now, Mike?
Yes, sir.
All right. This is Biospatial. Biospatial is a software as a service contracted by the New York State Department of Health to provide analytics to assist the department and our participating partners in identifying and using data to make it actionable and to see how we can manage to respond. What I have up on the screen now, hopefully it's large enough for you all to see, is an opioid dashboard that's designed by Biospatial. I've limited the data to just the southern tier Remsco area, so Chemung, Steuben, and Schuyler counties. And this is for a 90-day period. Over 90 days, you had 77 suspected overdoses. Keep in mind this goes back into 2022. 2 fatalities. One of those was already this calendar year. And 1 incident state in 3 counties. Get on here, this gives you a report by week. You have non-fatal. Fatal are the burnt orange reddish ones. If you want to see the numbers that are associated, you click on the number button up here. You want to download this particular chart. You click download and it downloads it as a PNG file. And then you get to see how you're progressing. During the week of January 22nd, some of you may have already known this, we had a potential outbreak, or an uptick rather, that's been building for some time since December 11th. You know, the week of December 11th, you had, you had more. Started with a low of 4 and then to 6, 5, 6, 9, 13, now 6 and 8. So you have a, fluctuating burden on your EMS system. Scrolling down, this chart gives you an idea of what hour of the day those incidents are happening. So this is, starting at midnight and going through 11 p.m. This gives you an idea. It's not like there's a particular time period that is reasonably high for an overdose period. When we look at other areas of the state, sometimes it'll be the post-school or just before school lets out. Sometimes it'll be Friday and Saturday night. So it just gives you an idea on what it is, when they're happening. This part of the dashboard over here is for the milligrams of naloxone administered. And again, it correlates to the week and the number of incidents. January 22nd, you might recall earlier, had 13 overdoses. So you would expect this number to be high. It gives you the average per patient. The line is the average per patient. The blue is how much total was given in that time period. Then over here, you have naloxone administered by route, whether someone endotracheal, intranasal, intramuscular, intravenous, other unknown, you can cross out what you don't want to see. Prior to EMS is like if it's what's reported on an EPCR. So if a family member administers naloxone, or a cooperating agency does, depending on where the incident occurred, this would be listed as prior to EMS's engagement with it. And this chart over here is all that of what EMS did. So this gives you, this records by event day gives you an idea of, when things were administered, and again, or when they happened. Again, January 22nd was a rough week. And then this is a heat map, by county in this particular situation. So if you're, if you click on the county, it'll give you how many records, what things were happening in that county. And keep in mind, I don't know what's in each of your 3 counties. I know that when I come to visit Mike, I go visit him at a former funeral home. So that's the extent of my knowledge of a majority of your region. But all I know is you have some great people down there. We currently use the Montana definition in New York for identifying whether something is an overdose or not. This gives you some age and gender demographics. Males are blue, females are this reddish color. That gives you an idea of the age ranges, one patient of each 70 to 79. But what we found across the state, a majority of the patients do appear in the 20 to 45 age category, which here on this chart is split up into 3 different lines. And then race is a little squirrely right now of a data point because it's not being universally collected the way we'd like it to be. And then this gives you some incident summaries related to that. We do have the opportunity to look at Mike will have the opportunity to look at other dashboards. So the quality measures for the regions are being built into this. So the first one being, is there blood glucose testing with stroke? So, on potential stroke patients. And let me see, I believe this is the whole state right now. I don't believe it switched it over because it went to a different measure. But this gives you an idea of what is being accomplished across the state. And we're going to be showing Mike, doing some hands-on training with the program agencies. We're going to train them in 2 groups. Most of Utica West will be one group and Albany South will be another. And we're going to do the training in person so that everybody gets the hands-on, gets some additional help in that. What we'll be sending Mike, quite likely, from what I understand, is a data use agreement that outlines what he's able to do with this data and how he needs to protect the data. Not anything that's out of the ordinary, but it wasn't covered in the program agency contract, so we have to go through and do a DUA related to that. So I know one of the key items that's been of concern, and I don't use this as much as I have a staff member who manages this, but he's in a class right now. So when Mike emailed the other day and said, so what do you think about coming on and doing this? It's hard to say no to Mike Pirozzolo when he asks you to come to a meeting. There we go. So you're seeing, when there's a need, that map, we haven't been able to get them to fix. But start talking about your volumes. Yeah, this covers the whole state. Talks about your volumes. So if we take out the Fire Department of New York and Senior Care and North Shore University Hospital, you see some larger numbers up there. But this includes the entire state right now. So, but Mike will be able to look and access the data that comes into his region for either for patient offload times, which is a hot topic across the state that we're aware of, but also incidents that happen in the 3 counties of the Southern Tier REMSCO. So we're putting together a whole training program for them. Probably spend a day somewhere with a laptop and a computer and in a room and just getting lots and lots of training to understand what it is. Eventually, the plan is that we will, the EMS agencies will be able to access their own data and to use the quality measures that the state has implemented to be able to assess how they're performing as an agency. So that, they say, oh, the state built these quality measures, but how do I go about doing that? If I remember right, Mike can correct me, but you have one agency that's rather large in one of the counties. So they might have a decent reporting program, but not everybody does. Yeah, this puts the data in all one place and say, hey, I want to know how we did regarding quality measure number 1, which is the application of the performance of a 12-lead EKG within 10 minutes of encountering a patient who is complaining of chest pain. So, the EMS agencies will be able to do that. Those are all built in. It's just about getting this and the information out. A DOA is not, to our knowledge, is not required for the EMS agencies because we are only sharing with them the data that is about their agency. So we don't need, we don't believe we need a data use agreement to do that. So that's where we are with that. I tried to make this really rather quick, but since the opioid grant pays my salary, that's always the one I start with. Are there any questions?
So we'll adopt the state metrics, and this will report out. We can look at this by agency, by region, and by state, correct?
Yes.
We can see how we compare to. Thank you.
Thank you. If you have any questions, Mike has my email address. He's certainly not afraid to use it. So by all means, you can forward the questions on through him to me, and we'll be happy to get back to you. But thank you for all the work that you do to ensuring the high quality care out in the Southern Tier region, and I look forward to continuing to work with you.
Thank you, Peter.
Thank you. All right. Hopefully this will seed the field for some good QI projects.
Yeah, I mean, the data from the state is also, outpatient clinics are seeing 6 months of morphine again. So it's not just fentanyl, heroin starting to sink back into the picture. We're gonna like make sure different things. So the amount of Narcan has been incredibly variable from like 0.5 milligram to like 16 milligrams in single dose, which is an outstanding again.
So the important thing about that, of course, is it's only data reported. If the police department goes out and what it is, something with Narcan, not going to show, may not show unless EMS documents that. So, and that's where a lot of follow-up is for PDs.
Maybe a reminder to agencies and providers of best practices to record the treatments rendered prior to arrival. I know
There's a lot of variability with that.
we should do very well because law enforcement officers are quite proud of the 8 or 12 milligrams
Yeah.
that they push before we get there, so it's easy to document.
I wonder though, if we'll still be in that recorded because it's just in the narrative.
Well, no, so at least with, the charts, I'm sure we other things as well. There's a page where you record treatments that were rendered prior to your arrival that we use, most commonly for transport. So basically, if I were to take transport from you and you had administered a heparin bolus, you're gonna have an infusion and start to put I might have acted on those things. Or if the first responders administer aspirin, obviously, if I don't document some of the chart, I'm gonna take a few days for my administering. But it's in the prior to when I arrive with this one to the board. But certainly, that data can be pulled out, as well, under, because we document exactly who did it prior to our, whether it was law enforcement, first response, the, infamous nurse on the unit. That usually ends up being TNA, but that's another story.
That's a good point, though. All the agencies need to realize that the narrative is not harvested for anything.
Right.
A good narrative is important, but
Right.
it doesn't hit it, that's the dad one, it goes nowhere.
Yeah, because I think, agree, the PMS report is often not in.
We've kicked a few back,
Right.
we'd rather through their narrative, and there's nothing above. I mean, they did a full code, and I don't think they documented anything up above, but they described things beautifully.
I mean, it sounds like that, itself would be a great QI project.
Yeah.
Looking at the quality equivalent to things not being documented where they should be, but even from an area.
Kind of reminder that to best practice. So interestingly, the problem, I can tell you because I've been there, I'm still there sometimes. We didn't always do PCR by checkbox. We used to do PCR by which country Michigan. For older providers, it's difficult for me to not write things and just let a chart stand and check box. Or a younger provider. They don't understand what is writing the narrative that is descriptive of what you do. That's not a statement on what you better or worse or what's good or bad. It's fairly scientific, different.
I can tell you that I have in the past had a chart that's all checkbox and it's sent back to me. I don't remember giving comparative to saying my handwriting now example. I mean, it's a different one.
Unfortunately, some of them also learned that, like in image trend, I don't remember the other one, image trend will write the narrative. It harvests stuff out of above and writes it.
Or the best kind of narratives.
But you look out, we can tell an image trend there. Everything's a sentence and there's nothing to spell, nothing. It's kind of pretty,
Well, I have a friend as a doctor who delights in we posting things that he reads from charts that he's doing from colleagues who dictate and this dictator from. I don't mind whoever it is that copies the stuff that. Yeah, the dictator is such an.
If you misinterpret it, it's gonna be.
Those are some extremely interesting. If people don't prove the.
So from the pro basic perspective, just so everybody understands the QA that we do on charts, we can look at anything in image trend, testing, Dr. Delivery, Dr. Color, and look at anything there. We go through those and go by agency. We try to hit every agency at least once a month. And first thing we do a quick flush is see if there's anything abnormal. There's a score. If the scores are low, we've been and look at it to see where they're data point. If the scores are all 100%, we also go in there and look at it to see if because there's tricks to not creating more fields. if you answer no to something, it won't drive more appeals. We try to look at those sorts of things. And if we come across something, we try to contact people directly and say, you might want to revisit this. Sometimes they don't take it very well, but it's just to get it where it needs to be. We also look to see if, you know, if we know, if EFD has nothing in this week, we know that it's anything that we're running, it's got a call a year. There's not a day that they go by something. So if we're missing a lot of stuff, seems like we're missing, we'll call and say, is the link broken between, are you not doing any? Or did you not have any calls? Did you not input them? Did your provider not upload to the image track? You know, it could be a lot of scenarios. That's to the extent that we look at it. And you know, if we had more time, we would, but we just, you know, 1.8 program agency here, so.
Make sure that software that they should have it and check the boxes.
Yeah, that'd be great. That'd be really nice, because then it doesn't become double work. Because it is double work. Why should you put it in an arrow and then have to do it again? It's just.
The chemical learning, some of the correlates in the MTs should not wear narratives.
Yeah, I mean,
Because it's better remains down on the rule. Thank you.
yeah,
And
well,
this is the type of narrative that rules it out.
we could probably spend a long time on that discussion, but since we are recorded, we'll probably have to table that comment for another. Well, a couple of things that we still have pending is, unfortunately, since we didn't reach quorum again, Schuyler County, the new EMS agency, the secondary agency that is now open and running. On the next visit, we can talk a lot more on them if we can reach quorum and give them final approval. If we're still just executive session and not a true meeting, we can't really do anything further than what they already have permission, and provisionally they're practicing in the region. Rather than beat a dead horse and have to have this discussion more than once, we'll table that for next time, but we continue to let them operate as they're operating. Our ED times, we're not hearing a ton from our region. When everyone leaves the region and tries to come back, that they get stuck for hours at a time. And I like to think that we're prodding ourselves at just getting the ambulance unloaded and back into service, because we have so few. We have 911 needs that need to be met. So unless we hear anything else from the region, Donnie, Jim, you got anything? I'm not on the sure yet.
Note to them, maybe, you know, just another phone call, but if they have extended wait time, they need to know how to stay.
I mean, if you're ever extended wait time at Arnold, you can always let meet myself or Jim Bowen know, and we'll look into why you're having an extended period. I feel like at any of the local hospitals, if you tell the director that you're experiencing some sort of issue, routinely at the facility, we'll look into the issue and get it taken care of. Sometimes it's just a matter of, we had a FDA ambulance that was just standing in the hallway. The guy had never been to Arnold before and just didn't know what to do. And it took him like 25 minutes to unload the ambulance because he was just standing there letting other people walk past him. He thought someone was going to come up to him and start the triage process on the stretcher. So that's not just fine.
Oh, well, not too bad.
Well, he stayed in the back hallway. Like, he was literally in the back hallway. He's on camera. So like, we see that there's someone on camera going, what the hell are they doing? So another ambulance walked past him. So we're like, all right, we have a different patient. Let's take care of this one. And then we still sit there.
For what it's worth, through the last few months, the smaller hospitals, the community hospitals, really have been doing a steady job of minimizing wait times. If I get asked to wait somewhere, I know it's true because everybody has to. You know, because they're very helpful. They'll come out, triage the patient, say, hey, it's going to be a few minutes, but we're doing the best we can.
And I know sometimes if the patient is not sicker than other people that have been waiting longer, so they end up going to triage, which, you know, they feel like they shouldn't because they use the ambulance. Sometimes the crew feel like they shouldn't because they're the ambulance crew. But unfortunately, what you're saying is sometimes the beds are left full and there's nowhere else for them to go.
The experience has been in those large hospitals, we passed through a triage nurse. And on a few occasions, I had to go find a doctor that he would come see this. because I think sometimes we can get a little overwhelmed, things that should be on this one. But at the same time, I've seen crews where they're every patient is a critical patient that needs to go right now. I can understand, we don't want to so many times, but locally, locally, the hospital is getting down and everything. And diversion doesn't seem to be a good issue like the ones that we.
The state says there's really, unless your equipment is failure, then there's no diversion anymore, so.
Yeah, but I noticed that in Valley County, has been professionally on diversion, so like, that's what it-
I mean, if Corning goes on diversion, it's not that Arnold's getting this busy, if Arnold says going diversion, it's not that Corning's getting this busy, so it's a matter of who you're diverting to, and you're still gonna get the same volume, it's just a fancy title for, oh crap, yeah.
Did we verify if somebody at the hospital is looking at your bar?
I don't think so.
So that might be something, someone needs to have access to the bar and look at that. It produces all the diversions across the state. It's saying that we had one used to do the radio call, we're green, green, red.
I still get emails from the state every day, somebody was on diversion.
They had said they were gonna stop that, and all of a sudden, everybody go look at your bar.
I think regionally, it's just if Arnold, being a stroke center, if our CT scanner goes down, we're on stroke diversion. If you're a cat lab, all of a sudden, just that you're on diversion, I mean, it's just resources like that. I don't think the hospitals in general can go really on diversion anymore, because if we're that busy that we're overwhelmed, the other hospitals in the area more than likely are in the same condition. So you can call it diversion, you can call it whatever you want, you're still gonna get the same people, you're still gonna get the same volume.
I guess what I'm trying to say is, people appreciate it.
Yeah.
Appreciate
Oh, yeah.
it.
Going on to the other old business is election of the chair positions for the, and the state CMAC rep. I can't make it to CMAC because that is the day that I work addiction medicine, so the day they decide to hold a meeting, I can guarantee almost any week, I can have a couple days off, but I can guarantee one day a week I'm working, and it's always the day they hold CMAC. That being said, I can't go if somebody has a strong interest. We would gladly like to hear that. We can work on getting you as a state CMAC representative. And if somebody has a strong interest in being either the chair or the vice chair of this meeting,
We can't make these decisions until you're four.
we cannot. However,
I volunteered to.
yeah,
See that.
that's what we're just waiting for a quorum at this point to go over.
Actually, though, it's been a while since I was in my office. I think that the rewrite chair can actually make the appointment.
Okay.
Set it to the room, so, Mike had talked briefly about it. There is no requirement for being in our board position. There are hospitalists, there are physicians, and I think those perspectives are important. Especially in the state bodies looking, looking at things perspectively.
There's more restrictions on being a medical director than there is on being part of these bodies and being the chair or the state representative.
The urgencies have taken 9 months to a year to vet
Yeah.
somebody, so Rob is still seated until.
Yeah, if we can, if anyone's interested in taking either chair or vice chair, please let us know. Otherwise, I have no problem sitting here. Like I said, I've been down the block, so I'll be here anyway unless I'm working. But if somebody wants it, don't have the strongest ties to any kind of my jobs right now. So therefore, it's open. There's a couple of things on here as well. There's a request for BLS CPAP. Which agency was running that one, Mike?
It's rather rude, no board,
No court, okay.
He would like to see that, but requires policy.
Yeah, I think for the next meeting, if we can get him here, he can kind of explain what he's looking for. He was asking me when the next meeting was, and I think he was working, so they can extend him an invite for the next meeting, put him on the agenda for the next meeting, so he can kind of give us a rundown of what he's looking for. And if his medical director is in favor, there's already a state policy for it, so.
Actually, CPAP is,
Yeah.
He's go to practice already, it's in a cloud of protocols. And I think it's long overdue for
Yeah,
basically.
I think it's just a matter of, we need someone who can teach them how to use it and show them how to use it and make sure that they're properly in service, because the fact that they're able to use it doesn't mean they know how to use it and how to use it effectively.
Oh, what a good responsibility to provide.
Well, that's why I want Robbie here. He always has a lot of great ideas, so I want to hear him here so we can verbalize them. The state sustainability report. We sent this out to the whole body. Yeah, has anyone read it yet?
Right.
It's nothing groundbreaking, nothing surprising, but we're seeing multiple levels of the system struggling to maintain and struggling towards failure at this point. EMS statewide is certainly one of them. They have to collect money, they have to keep their doors open, and that's a struggle. Seems to be tied to reimbursement and increasing salaries, which trying to keep up the times is, you hear a lot of the basic EMTs saying that they could make the same amount of money flipping burgers at McDonald's and they wouldn't have the same risk of being on the road, of traveling at high speed, or going into somebody's house. So, yeah. And not for nothing, we do have reports of some of people at hospitals not being the friendliest, so therefore, you know, it's not like they even get the bonus, so people not yelling at them when they would have done. So,
Like Greece is pretty hot though.
huh?
Like Greece is pretty hot.
Yeah, but so are some of the, if you've ever been in New York City, so are some of the projects.
You know, there's something to be said for free burgers.
Yeah, the grease smells a lot better than some of those projects that I have mentioned.
Uh,
The reasons change.
Now, this is sustainability like they were, they outlined 25 recommendations. I won't go into this, but 15 of the 25 recommendations were addressed in the governor's budget. There was a lot of activity, it's really this month, regarding the state budget process and the fact that this is the second year in a row the governor's given lip service to emergency medical services in New York State, the issues facing them. That was somewhat dismayed because throughout her speech, he reiterated that EMS, the provision of EMS was a matter of transportation. However, the budget proposal includes a robust expansion of mobile integrated healthcare through the medicine initiative, a robust amount of money for EMS initiative.
Can I ask a question on that? The Care Compass Network, it's like this third party. I talked to their business director, and he said they put out a proposal looking at paramedicine like a couple of years ago and didn't get any answer back. And I told her, I said, that's so bizarre. I hear you guys asking about paramedicine.
So the fight at the state level comes from the New York State Nursing Association. And it's a turf. Anytime and through COVID, a hospital has suggested extended scopes for paramedics. And last year, the budget proposal was ultimately defeated based on stated and report from that declared that using paramedics in any place other than the back of the ambulance would be detrimental to the well-being of every New Yorker and would just be done right wrong because all persons think very well. This year, they're trying to strike for better nurse-patient ratios, but they don't have it. So, you can't have it for this. But that's the reality.
We do so much telemedicine now without it. So many times you think, oh my God, if the paramedic showed up and we, wanted to do a telemedicine visit, it would be so easy for us to.
So the interesting thing is there was internal discussion about that in Chemung as well. There is a project floated in New York and it's available in 6 counties in New York, whereby paramedics can enter into it's called treat place program.
Yeah.
And, the field providers, are able to take 911 calls, their triage. It's supported by MVP healthcare, which makes sense, because if you're an insurance company, you want to figure out how to control and stabilize cost of evaluation and treatment, right? So these patients go through a special 911 triage and get mated with AMS to go out, do the assessment, initiate a telemedicine consult, right? And the goal being ultimately to keep the patient at home, right? The problem is, as agencies gave us that in on a meeting when we discussed the problems and pitfalls to where the project is right now. Out of thousands of EMS calls, they think maybe 200 people on the call this. The problem is they're having trouble getting field providers to engage. Because at the end of the day, most of these calls result in, well, it's just taken to the hospital. So those kind of happen around TV.
Yeah. And then,
And
you know,
in some places, there are not yet alternative destinations where patients can go. 24-hour urgent care is not the normal, right?
there's, I guess, there's a bill going through the legislature, which looks like a $13 billion bill trying to capitate Medicaid. And so make all Fidelis patients, basically capitate value-based reimbursement. And so you wonder if that.
So the problem, from my perspective, and from what I was hearing about a lot of the other field providers who have experience, is we're hamstrung by our scope of practice. So basically, these providers will win, they'll do an evaluation, they'll initiate a telemedicine consult.
Yeah.
And that's the end of that field provider's involvement. Because now it's a relationship between patient and telemedicine.
Yeah.
And the paramedics for an anesthesia just left to stand there doing that. And I think in a perfect world, the people that are building this program would think outside the box and say, you know what, if telemedicine consult believes the patient would benefit from a script, you know what, maybe I should run and get that script and get it back to the patient and make sure that they have. And that's just one example. Really, there's a disconnect.
Yeah, it could be as easy as integrating as easy with hospice, like in terms of like the nurses that go out with hospice. I mean, they're able to, it just seems like that could be.
So it's interesting you mentioned hospice because a few years ago, the Finger Lakes Rec School had a pretty robust hospice protocol for field providers. We understand that it's difficult sometimes to get hospice nurses out during the on-call hours. And at the time, paramedics were allowed to, their scope was expanded to appropriately care for hospice patients at night at home until the nursing law put a splash on because paramedics were doing nursing things. And that program was ultimately that. And it's a shame because it made perfect sense.
It just seems like there's a lot of potential for this with how much of that type of medicine we're doing normally anyway.
That's what you said that some of these telemedicine turned into a transport, and that's just made to the crew or something. But our crews have found that there's some time the patient refuses, and by going on and doing it telehealth, the doctors are able to talk to patients.
I feel like a number of times I've been pulled onto a radio call just to counsel the patient that yes, this paramedic knows what they're talking about. They listen to them.
Yeah. All right, I was just curious. I didn't mean to.
Well, and that's why, like I said, different perspectives is needed.
Yeah.
At this feedback table. It will help push some of these initiatives farther forward, but our biggest hurdle right now is nurses and beyond. So anyway, to cut back, the STREMAC and SEMSCO passed a resolution to support the governor's budget nobody's exactly sure what they want to do exactly with these 10 districts. Either who they answer to or any of that. But they want to throw $27,000. So obviously nobody wanted to support that. And there's a section on significance in that nobody wanted to support. But beyond that, we would ask if anybody has connections with their politicians, please support this initiative. They're afraid that if it goes down in flames the second year in a row, by next year, the governor's not going to be real interested in helping us. Our time is passed. So we're gonna pause.
You're done.
I mean, I would like you to make a motion, sir. I look forward to it. I make a motion to,
During the
well, thanks, Gail, said exactly.